All right. Good morning, East Coast. So the East Coast, West Coast, and around the world, trying to live up to Dr. Kenora Jane Spangler's introduction. Welcome to our first fellow project of the year for the 2025-2026 Fellows year. We're excited to have you guys join. Our inaugural fellow project lecture is also always given by the immediate past president of ASMBS and has been for the last 6 years. Um, and so we will be having a talk from Ann Rogers this morning. Before I introduce Dr. Rogers' talk, I have to introduce the people you're going to see on the screen for the year with me. Dr. Rickesha Wilson is an assistant professor at Cleveland Clinic. She is the immediate past chair of the Public Education Committee for ASMBS and is heavily invested in fellow and resident education at Cleveland Clinic. She's the co-director of this series, the Fellow Project, and excited to have her with us today. She will also be our moderator for questions and your kind of go-to for all important information. Um, Excited to have her. Then we also have a special guest today because of a weird change up, which I'll tell you about in a second. Dr. Adrian Dan is joining us. Dr. Adrian Dan is a past chair of the Bariatric Surgery Training Committee. He is now on the board of directors for ASMBS, and he is our liaison, making sure we are living the best bariatric surgery training life we can. Um, and he is here as a leading expert in the history of bariatric surgery. And then we also have Dr. Faiz Shariff joining us this morning. She's also on the Bariatric Surgery Training Committee with their team in Houston, Texas, as a bariatric surgeon. She's the director of robotic surgery at her hospital, and the one of the leaders for the Bariatric Happy Hour, which Dr. Wilson will be telling you a little bit more about in a second. So Dr. Wilson, why don't you go ahead with our announcements for the month?
Happy August, everyone, and happy start to the fellowship year. I presume we have mostly new fellows. We may have some old fellows who are transitioning out of fellowship to new jobs, but a few announcements for you. First off, of course, the fellow project, it's every first Friday of the month. Besides, maybe some special months where there may be some holidays. We may change the dates, but we'll let you know about that. For one, starting off with discussing the fellowship certificate that each of you will need to work toward. Once you're done with your fellowship training, it'll be important for you to keep up not just with your case logs and your inpatient and outpatient encounters, but there's a new requirement for the cognitive curriculum. In the past, we've had fellows submit their didactics from their program as sufficient for the learning objectives. But now this is the first year where we are requiring fellows to actually watch the fellowship project lectures through the learning management system. And that's going to be the mandate for your cognitive curriculum and the didactics. And this puts everyone on an even playing field. And we've had a lot of the leaders here today helping to coordinate that over the past few years so that we have lectures that we know cover what fellows should know. So be aware of that. For any fellows who are joining from last year, the application window, I believe, is August 1st to October 1st, and then we'll notify you of your certificate January 15th to February 15th. So be aware of that. That's a change. Also coming up, ASMBS weekend is in Louisville, Kentucky, and early bird registration is by September 30th for early bird pricing. But this is a more intimate meeting. It's smaller, but great lectures and great opportunity to network and get to know people, especially leaders in ASMBS and some of your colleagues. And so if you are interested and are able to go, I think that'll be a great opportunity for fellows to enjoy. You can host a walk through the Trail Foundation at your program. Be aware of that. There's also another educational opportunity through the Bariatric Happy Hour, which has been hosted wonderfully by Dr. Shariff here every fourth Thursday, correct? There are different lecturers and leaders in the field, and we review landmark papers and then also techniques and videos from surgeons. So it's a phenomenal, also a phenomenal platform to learn and network. And we have fellows host that. So if you're interested in hosting, there's a way to put your name in the hat to sign up for that. And then my last announcement is just if you potentially missed any of the lectures from our ASMBS meeting back in June, there is ASMBS on demand. There are lectures available that you can still go back and watch, and so and also get the CME credit for that too. So log on to asmbs.org for more of that information, and make sure you're a member throughout the year so that you get the weekly updates. And that's all I have.
Thank you, Dr. Wilson. I guess I forgot to introduce myself. I'm the director of the Fellow Project, the chair of the Bariatric Surgery Training Committee. My name is Shaina Eckhouse. I'm at Duke University as an associate professor of surgery and the medical director for bariatric surgery for Duke Health. We are excited to have you join today. And we have the massive leaders of our team and in AASMBS for training on this call. And today we will be hearing from Dr. Rogers. Dr. Ann Rogers is the immediate past president of ASMBS. She's on the executive council and board of directors for ASMBS with Dr. Dan. She's a professor of surgery, Penn State College of Medicine, and the vice chair for faculty development. She's also the program director for the Minimally Invasive Bariatric Surgery Fellowship at Penn State. Unfortunately, she had some travel woes and is actively on a plane for the last, Eastern time, 37 minutes, and is headed to the same location as Dr. Dan right now for a board retreat. She is still giving our talk this morning virtually, and that's why we have Dr. Dan and Dr. Shariff here to help fill in the gaps and keep the conversation going. So James, if we can go ahead and get that video started, please put your questions in the chat and we'll be answering them at the end.
Hi guys. I wish I could be there in person, but unfortunately I'm on a flight to Colorado, so Dr. Eckhouse was kind enough to let me record this in advance and tell you guys a little bit about some metabolic and bariatric procedures that are of historic interest. And it's actually going to include some things that we do today, but a little bit about the history of what we do. So I'm Ann Rogers. I'm the immediate past president of the American Society for Metabolic and Bariatric Surgery. So let's go ahead and get started. I have a couple disclosures that will not have any bearing on this talk. So the first operation that was kind of published for what was at that time thought of as morbid obesity was the jejunal-ileal bypass. And it was kind of published in 1954 by Linner and Kremen. It wasn't really published, it was just mentioned in this proceedings. So these guys were doing research with dog intestine, and they had come up with an operation in dogs just to study the physiology of their intestines, and they decided to perform this operation in a human being. And so they just mentioned it at the end of this proceedings paper. And so they said that what they had done to some woman was they took 36 inches of jejunum and 18 inches of her terminal ileum. And that is her entire absorptive capacity. That was her entire area of absorption that she had. At the present time of which they spoke, she was quite happy. She did not have diarrhea. She ate whatever she wanted. She had a full-size stomach, and she was, quote unquote, slowly losing weight. So they performed this operation a number of times, and they were quite pleased with this operation at first. And this operation was done a number of times by other people, and several variations on this operation, the jejunal-ileal bypass, were done, one of which was the jejunocolic shunt. So it was even more malabsorptive. The jejunum was hooked up to the colon by doctors pain and DeWind, and patients did have pain and DeWind, and so some bad things happened to patients who had these operations. Those were things like diarrhea, steatorrhea, malodorous, not just stools, but wind. They would get profoundly dehydrated and electrolyte imbalances. They would get joint pains and bone pains and kidney stones and fatty liver, and this would go on to liver failure, and a lot of patients did die from these procedures. And so those patients who did not die, many of them had to have these operations reversed. There are small numbers of patients who still have these operations and they're running around. I know a guy who came to me some years ago having had this operation, and he was toying with the idea of having it reversed because the only way he could eat was to make up a tray of food and sit on the toilet and eat, because it would simply wash through him. Unfortunately, his wife was dying of cancer at the time, and so if he was going to eat, he would have to eat over the toilet, but he was too busy caring for her, and so he said he would come back when it was a good time, and he has never come back. So he was lost to follow-up, but it takes a lot of work to reverse these operations and get patients healthy enough to undergo a reversal. So this is what this operation looks like. The patients have a normal full-size stomach. They have just a little bit of jejunum, and it's hooked up, generally speaking, to the terminal ileum, and they just have a little bit of terminal ileum, and that's their entire absorptive capacity. It's a very short common channel, and much of the small bowel is just flapping in the breeze. It's a very, very long, completely defunctionalized limb. And what I mean by defunctionalized is that nothing really is flowing through it in an antegrade fashion. So there's no food or spit or digestive enzymes in any way flowing through it. So it just sits there kind of stagnant. And that allows for bacterial overgrowth, and this bowel tends to become a petri dish of sorts, and it also becomes hypertrophic, and it becomes a little fibrotic string sign after a while. So it either stops working or it just gets overgrown with bacteria, and it's a real problem. Now, the intestinal bacteria that live in that defunctionalized limb of bowel are really what causes the liver disease after jejunal-ileal bypass, as you see in this paper. And so these bacteria deconjugate bile acids, and you get really elevated levels of deconjugated bile acids in the bloodstream, and some of these are toxic to the liver. They produce alcohol, and so these operations are potentially dangerous. And in fact, all of the operations that are malabsorptive or hypoabsorptive are potentially dangerous, and we really have to be careful when we decide to take them on. And in particular, those operations that do have defunctionalized segments, and the conventional operations that we do today no longer have such things. So that's why those are operations of historic interest only. Okay. There is a paper from 2006 by Ramsey Dalal who gives a case report on how to reverse the jejunal-ileal bypass, and he talks about implanting a feeding tube into the defunctionalized limb and doing trickle feeds through this defunctionalized limb. And it took about 3 months of sort of ramping up the feeds into the limb to get it to the point where it would tolerate feeds going through it, and hypertrophy over time to the point that it was becoming a normal caliber of bowel, and to have normal villi and really behave like a normal piece of bowel. And before that, it was really a piece of string. And so if you try to hook a defunctionalized limb together with a normal limb of bowel, you have size mismatch, and it's not going to work, and it's just going to leak and break down. So he's correct that it wouldn't work to just hook it together and hope for the best. So it's a lot of work. Well, so jejunal-ileal bypass really wasn't a great idea, and that's part of the reason that Ed Mason, who's considered the father of modern obesity surgery in the United States, in the 1960s, came up with the idea of the first gastric bypass. He and Ito were doing research, again with animals, but they came up with this operation for humans. And so the first gastric bypass that they described was actually in a loop formation, as you see here. So there was a fairly large proximal gastric pouch. It accounted for about 10 to 30% of the entire stomach volume. And then there was this loop reconstruction. So Ward Griffin, about 10 years later, came up with the idea of making this a Roux-en-Y reconstruction, because the patients who had this, the loop reconstruction, were kind of plagued with the kind of problems you see with loop reconstructions, which is generally bile reflux and marginal ulceration. So he came up with the actual conventional Roux-en-Y reconstruction, but while it was better for bile reflux, they were making these at those times with the kind of staplers that did not divide. So they had non-divided staple lines, which tended to break down, so you would get gastrogastric fistulas. And they still had a fairly large gastric pouch, which contained a lot of fundus. So there was a tendency for the pouch to expand over time, and it would get quite big. So they would either break down their pouch and end up with a full-size stomach again, or if they didn't break down their staple line, they would have a very large pouch, so they would have dysphagia. And we saw this also in the 70s with a variety of horizontal gastroplasties. People were constantly trying to find what would be the perfect bariatric operation. So this was in an attempt to not have any sort of small bowel involved in the operation, and they came up with all sorts of ways to just staple across the stomach, and these were all open operations. So they would get in there and get their hand around the stomach and staple from the greater curve, and maybe staple from the greater and the lesser curve, or maybe just staple from the lesser curve. And since these were non-divided staple lines, they would have to staple twice and then cut between the two staple lines, or maybe just do a non-divided staple line, and they'd get the same problem with breakdown of the staple lines. And these were kind of not great operations that some people had. And patients would say, well, I had a stomach stapling, and they didn't really know what operation they had. So when patients had a mystery operation of the 1980s, we would have to do some serious investigation to find out what on earth they had, because often it was impossible to get an old operative note. So if they had breakdown of the staple lines, they'd form a full stomach again. If they would have tightening of the staple line that would stenose, they would get vomiting and reflux and regurgitation. If they would end up with a big, massive pouch that would expand, they would be able to eat a lot, and they would get weight recurrence. So these were just disastrous operations. So people kept working and whatnot. This was the classic biliopancreatic diversion that was thought up by Nicola Scopinaro in Italy in 1978. And he was trying to come up with, again, the classic perfect bariatric operation. Now, the biliopancreatic diversion required resection of the distal 2/3 of the stomach. So it left about 1/3 of the stomach. So it was a good size gastric pouch, much bigger than what we call a gastric pouch in a typical gastric bypass today. Then it was hooked up to a piece of bowel that was your proximal alimentary limb that was about 250 centimeters long. And that was hooked into the terminal ileum. And it was a fairly short common channel of about 50 centimeters. Okay. So this operation is extremely hypoabsorptive, as you can imagine. So again, patients would tend to get diarrhea and flatulence. They would get the dumping syndrome because a high osmotic load would empty directly from the stomach into the jejunum. So if patients would eat a carbohydrate or fatty meal, then they would get the dumping syndrome. They could get marginal ulcers, again, because you had a good-sized stomach that was going right into jejunum. It was a very large proximal pouch, which was based somewhat on the greater curve, so that could expand. And since this is such a strange operation, it was harder to revise anything to a typical operation that we do today. And this operation is still performed in some European centers. So every so often, a patient who has had a classic Scopinaro biliopancreatic diversion will show up in the United States with problems, and we have to kind of figure out what to do about it. So what we do is a biliopancreatic diversion with a duodenal switch. And that operation and its loop configuration, which we call a SADI, those two operations circumvent most of the issues that we find with the Scopinaro biliopancreatic diversion. Now, in this country, people were still looking for other ways of getting around some of the problems that we've talked about. One of the things that they came up with was non-adjustable gastric bands, and they would just put mesh bands around the stomach. Lawrence Wilkinson in New Mexico in 1978 came up with the idea of putting a polypropylene band around the stomach. Well, as you can imagine, that would cause an erosion, and that was a problem. Molina in Houston, Texas came up with the idea of putting Dacron and then later Gore-Tex bands around the stomach. Similar problem. There's a lot of geographical things that happen with bariatrics. So these Molina bands are purely a Texas thing. Some people have come up with flow charts and descriptions of ways to deal with non-adjustable gastric bands if they find their way into your practice. This is one such flow chart that says, if somebody comes in and they have a non-adjustable gastric band, and this was from a Houston group, I think at Houston Methodist, so it was for Molina bands. They said if you have an eroded band, you can either try to remove it endoscopically or with what they called a transgastric and a combined endoscopic and transgastric rendezvous procedure, where they would actually put an endoscope into the stomach and then put laparoscopic ports into the stomach and jiggle around and cut the band and try to remove it either endoscopically or laparoscopically. If the patient did not have an erosion, but they just had a two-type band, they thought you could remove it laparoscopically. If you had a non-eroded band, you could remove it laparoscopically and then convert the patient to either a bypass or a sleeve. Sorry about this. Well, so then Mason realized that there were some problems with his loop configuration of the gastric bypass, and so he came up with this concept of the vertical banded gastroplasty, and this was in the 1980s, and he was still looking for the perfect bariatric procedure that could be done for everybody who was a candidate for a weight loss procedure, and hoping it would be durable. And this was a procedure that did not have any small bowel. It entailed, this was an open operation, again, where you got your hand in there around the lesser curve and you used a circular stapler, an EEA stapler, to punch a donut hole of stomach, and then use that donut hole to introduce a linear stapler and staple off a small pouch that was based on the lesser curve. So there was a lesser curve based gastric pouch, and then you would put a mesh or suture ring around the bottom of that pouch so that it would stay small. So it was a lesser curved base pouch that would not hopefully expand because it didn't have any greater curve. And then there was a defined stomal diameter that was kept that size by the mesh or sutured ring. And then there was no chance of malabsorption because there was no small bowel involved. Okay. But there were some potential disadvantages because, once again, these were non-divided staple lines, so they had a tendency to break down. And if they didn't break down, you had the possibility of stomal stenosis or band erosion down there, where this band or ring would either get too darn tight or actually chew through the stomach, and both of these things were seen. So patients who had these operations would either have total weight recurrence or would get so tiny because they were unable to eat and were vomiting all the time that they would get to 75 pounds, and they would come in and they would look like they maybe had gastric cancer. So patients who had these operations would come in complaining of either complete weight recurrence or an inability to eat, and after resuscitation one way or another, they would end up generally having a conversion, and this was usually to a Roux-en-Y gastric bypass. And when you're doing this conversion, the idea is to hopefully do it in a minimally invasive fashion, and it generally entails getting rid of all the metal and foreign body material that's in there, including all the staple lines, the mesh band or ring, and then being left with a pouch. And there's usually plenty of pouch to work with because these patients have been vomiting for one reason or another. So you're generally left with something like this. And I actually have a little video that I think I can play that just shows the beginning of this. This was with my fellow maybe about 3 years ago, just showing the beginning part where we're getting rid of all the metal and forming the pouch. And I won't bore you with the entire bypass, but it shows us doing this robotically. And she's stapling off a pouch. And when it was green, that was us using indocyanine green and showing the blood supply to the pouch, which is based on the left gastric artery. And she's just now taking out all of the staple lines, and you can see you could see if this weren't all sped up that there was a mesh ring, and there's a lot of material here, and all this garbage is old staple lines. Believe it or not, you have to trust me on this. That was all old staple lines, and so she was left.
Dr. Rogers freezes here for a little bit, but it's talking about the importance of taking out all the staple lines from a vertical banded gastroplasty or a horizontal gastroplasty when you operate on him. So plugging, going on both sides and removing it. Otherwise, you have the potential of creating kind of a closed loop obstruction, if you will. She will unfreeze here in a few seconds, and look forward to the conversation a little bit more about VBG conversions, as we are still doing a lot of them today. There's one more time she freezes for a short period of time. I think this is the longer part. Considering she's doing this from a hotel, I figured we would make it work.
Okay.
There we go.
With a pouch. Okay. So this is the classic biliopancreatic diversion with duodenal switch. And this was described by father and son team Hess and Hess in 1988. So this was originally an open operation that was done first in Bowling Green, Kentucky. And this is like the Scopanaro biliopancreatic diversion, except that instead of using a proximal third of stomach, it's got a sleeve gastrectomy. So it's all based on the lesser curve. So it entails a sleeve gastrectomy with transection beyond the pylorus. So these patients are left with a pylorus. So then they have a duodeno-ileostomy with a common channel of, or a proximal alimentary limb of about 250 or 300 centimeters, and then a common absorptive channel in the terminal ileum of about 125 or 150 centimeters, okay? So having the pylorus in place decreases your risk for dumping syndrome, and it also decreases the risk of having marginal ulcers. And having the sleeve based on the lesser curve makes it that you're much less likely to have any dilation of fundus. And this is a very difficult operation, and these biliopancreatic diversions with duodenal switch and SADI together account for less than 2% of all the bariatric operations that are done in this country. So they're not of historic interest. These are done today, but they're only historic in terms of being an open operation. So people don't do these in an open operation anymore. But we only have a CPT code for an open operation. So when people do these in a minimally invasive fashion, they code them with an unlisted code, basically, because it's not an open procedure. This is a weird operation. This is the Magen-Strauss and Mill procedure. This was first described, I think, in the 1980s by a British group in Leeds in the United Kingdom, by Johnston et al. It's so weird. It was done also with an EEA stapler and then linear staplers. So it kind of looks a little bit like a sleeve, except you leave everything in place. It leaves the entire ghrelin-producing cell mass of the stomach. It looks absurd. There is a group from Europe that described doing this laparoscopically. I mean, these patients don't have a lot of GERD for some reason, according to these authors. It's quicker than a sleeve because it doesn't require any gastric resection, and you don't have to take anything out, so you don't have as much port site pain as in a sleeve gastrectomy. But I can't find anybody in the US or most people in the world who actually do this operation, so I can't say much about it. I think it's weird, and I can't really think of much of an upside to doing this operation, so I'll just tell you it exists. Yeah, I don't know what to say. This was the original adjustable gastric band. It was invented by this guy, Lubomir Kuzmak. He did end up coming to the United States. He was the original guy who patented it. The patent, I think, was essentially stolen by Allergan. There's some lawsuits that you can find in the internet. This poor guy went to his grave, trying to get credit for this, but he never did. It's very sad. It's not necessarily historic. There are some people who do this, but it's really fallen out of favor for a lot of reasons. But band and its complications are on our focused practice designation examination. So it's important for you to know something about it. It's generally placed by opening the pars flaccida. So that's the gastrohepatic omentum. You have to avoid the vessels and nerves that are in the gastrohepatic omentum, so you open it kind of low. And then you have to find the right crus. You have to avoid the IVC, so you got to know the difference. You have to know your anatomy. You have to just kind of open the peritoneum on the medial aspect of the lower part of the right crus, and then you just aim up towards the angle of His, and you basically do a blind pass behind the stomach, okay? And then whatever you use, whether that be a DeBakey grasper or the blunt instrument that comes in the band kit, you take that and you grab the band and you pull it back through behind the stomach. And the reason you do this blind pass is if you do a lot of dissection, you're much more likely to have a big space behind the stomach that will allow for band slippage or gastric prolapse through the band. And then you buckle the band up. And I have something that I stole off the internet that basically shows a band passer. This is a lap band passer, and then there was a piece that would go through the lap band passer, and then you just basically pull it through, and then you buckle it up. Buckle up for safety, buckle up. Yeah, you pass that through, and we got really good at this, and it could be done pretty quickly, and you just pull it together and buckle it tight, and then we would put gastrogastric suturing laterally over the band in order to hold it in place. Okay. And then
this is our second time she freezes. As she's besides gastric suturing, there's also a anti-slippage suture to try to prevent band slippage, which is called the Emma Patterson stitch, which is on the lesser curve of the
so
stomach
during
to
this
severe to the
blind
band.
placed band encircling, I found this was amazing. A unique complication of band placement, a misplaced band encircling the abdominal aorta. Seriously, guys? So during this blind pass, they managed to pass the instrument behind the aorta. I would say don't do that. I can't believe they didn't pass right through the aorta, you know? So I always had my heart in my throat when I was placing bands. They call this safe and non-invasive. It's highly invasive and highly not safe. So I don't know. It's not an operation I enjoyed doing. It had a very high failure rate, about 44%. Very high complication rate, very high reoperation rate, very high insufficient weight loss rate. So certainly in my hands and in the hands of most bariatric surgeons, this was not successful, and that's why very few people do this operation anymore. So most places that placed bands have removed all the bands that they placed and then converted them either to bypass or sleeve. Most people find that if you convert patients from band to sleeve, you don't get as much weight loss as conversion from band to bypass. And I think that's shown itself to be true in most programs. But most patients nowadays want a sleeve, so sometimes you go from band to sleeve, and then patients give up and they go from sleeve to bypass. You know, and then there's a discussion of whether you should do it in one stage or two stages, and there are reasons to do it either way. And there are some people who do it all in one sitting because they think a patient should only have to undergo anesthesia one time. And I will tell you that my practice has been to remove the band so that patients can eat normally again and then put them through a bariatric program again, because it's been, generally speaking, more than 2 years since the time that they got their band, and they can re-enter the program and things will soften up on the inside and they can relearn how to eat, because you can't eat normally with the band in place. And then by the time they've gone through the program, things are soft enough again that it's easier tissue to staple on and have a good and durable stapled procedure. So that's about all I have to say on that, and so I will stop there. And if you have any questions, I guess you'll have to address them with Dr. Eckhouse. And so thank you for listening, and good luck this year. See you later.
That is the illustrious Ann Rogers in all her glory. And I love listening to her talk, because she always finds something interesting, like placing a band around the aorta, which is highly not recommended. Dr. Dr. Dan, I wanted to give you an opportunity to comment, and then Dr. Wilson, take it over.
Well, I'm just going to say that Dr. Rogers did a fantastic job of providing an awesome overview of the history of metabolic and bariatric surgery. It's only about 70 years, and there's a couple reports before the Kremer and Lintner papers and series. But the only thing that I'd like to correct as an Ohio person, Ohioan, is that the first BPDDS was done by Hess in Bowling Green, Ohio, not Kentucky. So Wood County Hospital, just south of Toledo. And I think that's just, she just misspoke, but just want to make sure Ohio gets the credit.
Dr. Wilson, I think you're on mute. You're talking to us.
Sorry, I'm in the pre-op setting right now, so I'm missing. But
Yeah, I think my question, and I'm on my phone, so am I missing questions in the Q&A or chat? No.
I got you. No, you're
So
good.
with all the historic procedures and whatnot, what is I think advice to our fellows? I mean, first of all, I think that history lesson tells us that we're ever evolving and learning. I mean, our colleagues that have gone before us and led the way and pioneered a lot of the things that we know today, they had to learn through it. What are advice for fellows once they get out early into their practice and maybe they see some of these historic procedures? I mean, what should the approach be for those patients and taking on maybe newer techniques that they didn't learn in their fellowship?
So, Rickesha, I love that you said that, you know, history is ever evolving, right? So, I think one important takeaway point is that since the beginning, and the very first procedure was done by a gentleman in Sweden who decided to remove 105 centimeters of small bowel from a patient in 1952. He was highly criticized because there were no animal studies. He never was able to explain why 105 centimeters. And the patient ultimately lost about 14 kilograms. Over 2 years, gained it back. But over time, she was feeling better, objectively, better bowel function, less blood pressure issues, fewer health problems. So um, ever since then, it's evolved, and we would not be where we are today had we not made the mistakes, so to say, and the trial and errors that we did over the 70 plus year history of metabolic and bariatric surgery. So that's important to remember that we do stand on the shoulders of giants. The operations we have today have had the benefit of studies that have over time refined what we do, right? It's like the cell phone. The first phone was very different from the cell phone you're using right now to communicate with us in this video conference. Over time, even the refinements, Dr. Harvey Sugarman definitely should be brought into this conversation. He was in the 1980s one of the first bariatric surgeons to bring rigor to the science of bariatric surgery. And he conducted an excellent trial that I think was published in 1989, looking at comparing the VBG, which Dr. Mason touted as the perfect operation, because Dr. Mason specifically did not want anything that has an ectomy or an anastomosis. So that's why he came up with the vertical banded gastroplasty in the early 80s. But comparing that to the open gastric bypass, and Dr. Sugarman did a randomized controlled study, and after a certain number of patients, they had to stop the study because it was very clear which operation um, uh, provided better results. We've never had that before then. It was just case series. It was just trial and error. The GI bypass of the 70s caused tremendous problems with bacterial overgrowth, kidney failure, liver failure, septic arthritis. And the Scopinara procedure was actually the first one to ever show an improvement in liver function because the other ones caused liver failure. So a lot of studies have been done. And then over the 90s and 2000s, we were a little hypersensitive because of the way that our discipline was viewed. And there were a lot of efforts to get excellent data, such as the labs study and MBSA QIP. Our procedures are amongst the best studied in modern medicine now. Also important to bring up is the Walter Pori's paper from 1996, where he said, "Who would have thought it that a bariatric operation is actually the best way to treat and bring diabetes into remission?" A disease that was forever seen only as a medical disease, right, without many surgical roles other than maybe a toe amputation. So, yeah, history repeats itself. It doesn't repeat itself, it certainly rhymes. And the lesson here, to get back to what you asked, Rickesha, is that as we move into the future and we have a better understanding of the disease of obesity and ways to manage it through medical modalities, we have to adapt. And you have to understand the medications. You have to maybe even get board certification to become a ABOM member and provide your patients not just surgery, not just medical therapy, but also understand when to engage our behavioral health colleagues. So I know that's a lot, but the history of bariatric surgery is still ongoing, and our response to the huge change of the pendulum in the last few years is going to be to get better, whether it's through robotics, whether it's through magnets, whether it's through decreasing the invasiveness and complication rates of our surgery, which are already extremely low. So those are the teaching points. I know that I've said a lot, but those are the take-home points for our fellows.
That's fantastic. And yeah, it just makes me think of the courage and the curiosity that the founders and the early surgeons had to have to keep our field moving forward. And I think we carry that spirit with us. I guess we can all share what that journey has looked like, adapting, doing new things we never did in fellowship that are part of our practice. I know Faiz does robotics heavily, not a lick of the robot in fellowship at Cleveland Clinic at all. And so I think, of course, looking into future jobs and, of course, having good partners, asking for help when you're unfamiliar with some of these operations. But, I mean, Faiz or Dr. Eckhouse, Shaina, can you share your journey and how you've been able to adapt in some ways in your practice early?
Yeah. Dr. Shariff, I think you should go first, but I have lots of thoughts. So you go first.
So, like what Dr. Wilson just mentioned, I didn't do any robotics in my fellowship, but what is important, a couple of things I wanted to kind of add to that, right? When you're starting off, first and foremost, what you want to focus on is like just doing the basics and then, kind of establishing that you're a safe surgeon and then taking on challenging cases. So from the get-go, if a patient comes to you about with these historical procedures, I might just pass on for the first 2 years and then start taking these patients on. And in terms of when you have a patient who has had procedures, I think in knowing the anatomy, knowing this is important. And I'll just share one of my stories that I recently did a case where it was a simple sleeve to bypass conversion, but then while in the case, I tried to get all these information in terms of op notes, did all the investigations, but always assume that nothing is going to be a standard cases. So my advice first is to know your anatomy, then assume if something doesn't look normal, that it is not normal, and then investigate that further. And don't be hesitant to take on new challenges. There are enough of us, and you will see this across the board that a lot of people are willing to help you on. Like Dr. Dan mentioned, things are evolving. Now the magnets are coming on, endoscopy is going to take off, right? So all of these things are going to be evolving. And I think what you can do is, even if you haven't learned it in your fellowship, there are enough people around you to help you kind of take on new challenges.
Yeah. I think be curious, live by be curious, not only as a trainee, a fellow, but a lifelong learner. Like 10 years into my practice, I am still being schooled and learned, learning from all my patients that I see. As we're looking at these historical procedures, I've had two patients with different types of JI bypasses every year. Well, two patients in the last year, but I see about two a year who actually don't want their JI bypass touched, and it's really fascinating. Um, and to be fair, actually, how they're doing, they don't need it touched. Um, it can be quite challenging to adjust and adopt and adapt because they're very high risk with how long they've had that atrophic bowel that Dr. Dan and Dr. Rogers mentioned. And then I think the anatomic evaluation that Dr. Shreve mentioned is so important. Sometimes patients will come in and they'll tell you they had a gastric bypass, and in fact, they had a duodenal switch or Scopenhauer procedure, or they had a VBG. Sometimes they say they had stomach stapling and they actually didn't. They had some kind of permanent band placed. So you're always having to double check what patients are telling you, because unfortunately, many people in the medical community just don't understand what bariatric surgery looked like 40 years ago compared to 20 years ago compared to even 10 years ago. And so taking the time to do that evaluation is super important. And then being willing and able to learn about the what all these different procedures look like radiographically and endoscopically is really important. So as you're a fellow this year, it's learning normal and then learning the abnormal and realizing limits. So when you first go out, you're not going to take on a JI bypass revision or a VBG revision. You're going to take on the straightforward, get comfortable with your anatomy. So when you end up with the weird and the unique and the different, it's not as scary. And then if you unexpectedly have like malrotation in the middle of a gastric bypass, it's a little less scary. Maybe the first time you don't do it, maybe the second time, maybe the second time you do it, maybe the sixth time you do it, because unfortunately I've seen way too many of those. But part of the cool part of our community is it's a small community and we're all willing to help each other. And you're seeing three of the people that I call on for weird and crazy all the time, which is why we invited them here today. Your fellowship faculty are going to be willing to take that phone call, whether it's at 2 in the afternoon or 2 in the morning, to help you out. I may have just volunteered a lot of faculty from around the country to take a middle of the night call who's going to be mad at me, but that's okay. I'll take the call because, to be fair, if you're not comfortable, ask for help. It's okay to back out, but at the same time, you want to be smart about how you start once you're done. You'll learn all the weird and crazy. Start simple and build up as you get comfortable.
That's so
Sorry.
good. That's so good. I love that wisdom. And the quote comes to mind: we overestimate what we can do in a year or two. We underestimate what we can do in 5 years. I
love
think
that,
be
Dr. Rickesha.
be gracious with yourself through this learning process. These cases are complex. Treating obesity, there are multiple ways that you can get into trouble with a patient with malnutrition and get them out of trouble too. And so really just be curious, be courageous, but be wise. And hopefully you're in a culture within your fellowship and beyond where you have room to learn and to grow. And it takes all kinds. It takes industry, exposing us to different technologies to better care for our patients. It takes conferences and meetings to learn the latest management strategies and all that. And so I think this is it's a journey of progress, not perfection. Every one of us on this call are in different stages of our career, but always learning. And of course, it's a humbling process day in and day out. And so just knowing that you're not alone with the challenging cases, even through your fellowship, it's a continuum of just learning and growing.
Right, Dr. Wilson, I'm just going to read out a comment that was, I think you're on a phone, so you might not see it.
Yes.
And also make a pitch for the bariatric happy hour. We have Dr. Bichelli who said, challenge is also getting the insurance to understand what we need to have revisions to correct the major issues, which is 100% true. And that's why I would urge you all to join us for the bariatric happy hour on the 4th Thursday of the month, which would be 28th of August. And I have a great speaker, Dr. Rob Cunningham, who's going to come and talk to us, especially about these topics. He is someone who's a third-party reviewer, so he doesn't work for any insurance companies, but he's someone like, if you dispute and you have your peer-to-peer, it goes to him. So he has some good insight as to what we need to do and how we need to document. So I'm just going to make a pitch. If you care about insurance and all of these things, then just join us for the bariatric happy hour, because it is a major problem. Getting these patients covered is part of it's going to be a part of your journey. During fellowship, I did not realize how much that plays a role, what happens at the back end. And I think while you're going, another advice to all the fellows this year is, while you're trying to learn, your technical aspects and everything else, we focus too much on the OR. But bariatric surgery also has a major component about, especially now with the patients being so confused with medications and everything else, you need to know how to run your clinics, your office hours, and the insurance part of it. So join us for Thursday to learn more about the insurance, if anyone else wants to add something.
Yeah, it's interesting because kind of to know your future, you must know your past, and I think a lot of the challenges we have with insurance have been borne out because of a bit of a sordid history that came from the 60s, 70s, and 80s of bariatric surgery, and kind of being the redheaded stepchildren of surgery as we figured our footing out. Now that we figured it out, we're getting better, but we're still trying to overcome the issues of the past. And so I do think some of our insurance challenges are coming from that history. Um, that being said, we have gotten since our quality improvement collaboratives, the MBSA QUIP, which an older version existed or a different version existed in 2005, 2006, and as it has evolved into its current state, has really improved our outcomes and improved like decrease the risk of complications. But insurance still has that memory, and that memory lasts a long time. And I think some of our challenges are because of our history. And so the foundation that Dr. Rogers and Dr. Dan and Dr. Shariff have talked about today, I think color a lot of both the positives and the not so positives or the opportunities that we have in our field, and not only with bariatric surgery, but treating obesity as well. Any final comments from the team before we let our fellows enjoy their first day of fellowship?
So Shana, I'm gonna just bring up one more thing. A lot of times, if they say if you wait long enough, something will come back. And when we look at the OAGB, it's really the third major reiteration of a loop gastric bypass. So interestingly, a lot of people probably did not know that the first iteration of the gastric bypass in 1969 with Mason and Ito was a loop bypass. Mason and Ito had done their training at the University of Minnesota, where they saw the effects of gastrectomy with Billroth-2 reconstruction on patients with diabetes. Those operations were done for ulcers. And there's actually literature going back to the 1920s that shows unexpected resolution of diabetes and obesity in patients after ulcer surgery. But then there was the mini gastric bypass in the 1990s and early 2000s that was quite vilified. And it turns out with a reiteration of that, where you make your pouch almost like a sleeve and preserve the insert, and now we have the OAGB. So again, who knows over time and in the careers of our fellows, how operations from the past will come back in other forms and other iterations, and be the operations of the past can be the operations of the future. So just keep that in mind. Always be open-minded. And I'll always say, I remember doing a type 1 distalization one time where it was the first time where I just didn't have enough bowel, and I felt that I would make the patient a nutritional cripple. And it was so nice to just scrub out, go to my cell phone, and I called Scott Shakora, who's published on that before, and he answered on the first ring and gave me some of the best advice I could ever ask for. That's really kept me out of trouble on that specific case. But that's always available, and I think that's a really nice thing to end on, is just the small community that our society is, the home that our fellows can find. And the ASMBS is a surgical home, one of the largest surgical societies in the world. And we're just really proud to be part of this and to see the Fellows Project now in its 6th year. And remember, the other ones are available online, free of charge on the LMS. Go back, because we've had some fantastic lectures over the past few years, and I'm just so excited to see where Dr. Eckhouse, Dr. Wilson, and Dr. Shariff and the rest of the BSD are taking surgical training over the course of your fellowship. So thanks for the opportunity.
So just one more thing I would like to add. Be your patient's advocate. Remember, these patients have been abandoned. They feel frustrated with all the years they've faced, the stigma. So be passionate about this. And I know everyone on this panel is passionate. We do what we do because we love that. I do foregut surgery and everything else too. I don't think any other surgery makes me more happier than bariatric surgery, because the transformations are real, not just in terms of like what the weight they've lost or the comorbidities that resolved. These patients, when they come back in 6 months to a year's time, you see them. They've become a different person. They go on to do different things. So have a lot of compassion when you first go on and that patient comes back to you with the nausea, vomiting, and you're like, oh my God, everything looks normal. Why are they this way? It's because there is a lot of changes that happen, including the hormonal changes, and that first few months is really hard. And be there for them. they have suffered a lot. They have suffered a lot of stigma, and from people like us, like physicians and doctors. If you hear the stories, that'll shock you. So just be there for them. And I promise you, this is one of the most rewarding things. And I might just ask all the panel here, would you do this again? Like if you had the choice to be a bariatric surgeon, and I know the answer, but for the fellows, please go ahead and share that.
100 times over.
See, I knew that.
100%. And just let me say that I know when we went through fellowship, the culture was different, the job market looked different. But let me tell you, this year, your skill set, I mean, maybe you'll get a bariatric job, maybe you'll get a general surgery job. You will treat patients regardless with obesity because it's rampant. And you will need to know that anatomy. If you're doing taking out a gallbladder for pain, you need to be able to run the Rulim anatomy and make sure there's not an internal hernia causing that chronic pain. Like, I hope that you soak up everything you can this year so that you can take it with you, because I call myself a general and bariatric surgeon because we're surgeons. The skill set you'll have to do anastomoses in patients with high BMI, I mean, that's priceless. Being able to work around the foregut, I mean, your skill set this year is going to be phenomenal. And ultimately, we want to be great surgeons to rise to the occasion and take care of people when we need it. And this skill set that you're getting in this year is priceless. And yes, I would do it again.
I love to say no just to be contrarian, but no, I would totally do it again. If I had to do it all over again, starting at the age I am right now, I would struggle and I would still do it because I love taking care of patients. They're super grateful because, to Dr. Sharif's point, they've been marginalized for a very long time. 40% or more, depending on the state you're in, have patients that meet criteria for class 1 obesity or higher. That's 40% of the population that's been marginalized by not only society, but the medical community. So we have a huge challenge ahead of us as physicians, because with time, the medical community and society will start to realize, hey, we've figured it out, but they haven't. And so we need to be those leaders to kind of pave the way for figuring out how we treat obesity as a disease, not only treating obesity, but when we're treating everything else. Because they still have all the general surgery and medical problems, but they're treated subtly different because everybody assumes they can't do it because their BMI happen or the weight happens to be a little higher. Let me plug a past presentation real quickly. February of this year, 2025, we had Dr. Friedman and Dr. Duncan talk about stigma and weight bias, and we had a patient on the panel as well. It's if you're able to, I would strongly encourage you going back and listening to it because it hits a lot of the points that have been brought up today. Not necessarily about history, but about how history has affected our patient care and how we can improve moving forward. And then realizing, if you put yourself in your patient's shoes, if I had nausea and vomiting for longer than a day, I would be a miserable human being. I would be horrible to handle with. So when you try to put yourself into your patient's shoes in the setting of them being marginalized their entire lives, then you start to realize, hey, I need to give them grace. And then that compassion may come, or that empathy can come. And sometimes instead of trying to fix the problem, first just say, dude, that sucks. And I'm really sorry you're experiencing that. And give them a moment to let that sit in so that they realize you heard them. And then start to figure it out. Be curious, be compassionate, be graceful. This year is going to rock. We got a lot of really cool talks coming up every month, and we have a lot of banked ones from Dr. Dan and his leadership as he developed the fellow project. So we're really excited for a fruitful year ahead. And I know Dr. Dan looks like he wants to give one last statement, which will be our final statement, so we can
I
end.
really do. And I'm going to go back to my first day as a fellow. Honest to God, true story. First day, 2005, at Cleveland Clinic, Phil Shower sits us down. And of course, those of you who trained with him, I know there's two people on this panel here. He's so busy, getting 2 minutes of his time. He said, guys, it's a year of servitude, and I will forgive you for everything and anything that you screw up, except one thing, and that's missing thiamine deficiencies and Wernicke's. And I'm going to follow up on Faiz's point. And when your patient's coming with nausea and vomiting for more than a few days, give them empathy. Also give them thiamine immediately. Okay? That's the most important pearl of being a bariatric surgeon. Don't miss it. It's not common, but it's more common than you think. And I can't leave you with a better pro for your first day of fellowship than that. And thanks again, guys, for the opportunity. So looking forward to see what you guys have in store this year.
All right. We'll see you guys next month. Our hope is to go over sleeves and technique and outcomes. Thank you guys very much for your hour.